It's another show, it's another episode, another learning. I hope you have your notebook ready, that you're going to jot out some notes, that you're going to write down when and how to detect. So on today's show, we are going to talk about hemorrhoids in men. Hemorrhoids in men. It's a common thing. You know, the funniest thing about men, you don't talk. Me, if I had a small swelling, I'm sure my doctor shall know. The surgeon around me shall know. Everyone, I'll make noise. So men hardly talk it out. And that's why we are bringing these things into your house to know someone else has undergone it, someone else can correct it, and when it's known early, you can be protecting yourself from something bigger like rectal cancers. So on today's show, you are going to bring Dr. Ogaya, that is going to bring a surgeon, that is going to bring some light on hemorrhoids in men, and it's a common thing even in women, how to detect it early, what are the early symptoms, and we are going to protect ourselves from something that looks so scary, but someone else has undergone it and has healed it. We need to just diagnose it early. So let's go and talk to Dr. The hemorrhoids in men, and it has been so, I guess we had that discussion with you, it is so much common. I'm wondering, is it now or it has been there? Just put some light on it, the hemorrhoids in men.
Okay, hemorrhoids. What are hemorrhoids? Naturally, when God creates something, He has to mitigate dangers. When the manufacturer of the vehicle manufactures it, he puts a braking system so that as it goes, when it's needed to stop, it has to stop. So even for men, you need to go for long calls. But you may have desire to go for long call and the conditions or the surrounding may not be adequate. So God has built in mechanisms to help you sustain until you reach the desired site. And one of them are the hemorrhoids. Hemorrhoids, naturally, everyone has hemorrhoids, but not everyone has hemorrhoidal disease. Everyone has what we call hemorrhoidal plexus of vessel.
Yeah.
There are three. There's one on the left and two on the right. When you look in the anal canal, and their work is when, for example, you wanted to go for a long call and the toilet is far or the condition is not conducive, you engorge them with blood and they put a continence mechanism. They plug the canal so that you are able to hold. You want to pass letters, unataka kunyamba na watu wako wengi. There are many people. You don't want shame. So you just tighten your hemorrhoidal cushion and you're able to hold. They help something called internal and external anal sphincter. So those are three mechanisms that help us to maintain. Now, naturally, if you follow the normal way, you drink enough water, you eat good amount of fiber, you don't have hard stools, you go nearly once or twice stool passage every day, you don't do anything that makes them to engorge excessively, then you don't have a problem. The problem with them is when you engorge them with blood to a level that surpasses their capacity to hold. For example, us men, when we lift in the gym, those ones who carry heavy loads, people with chronic cough, people with constipation, as you strain, you feel and engorge them with a lot of blood. Over time, the weight of the cushion of the blood overwhelms them. So as they are plastered on the wall, like this, they are on the wall like this, they start falling. They become weak and whatever is holding them to the wall is overwhelmed by the weight of them. So they start falling down. When they fall down, that is now what we call hemorrhoidal disease. Now, having hemorrhoidal disease is not the problem, but the consequences of what happens to them. Because now you have blood vessels that are full. Now, when stool passes through them and is hard, it scratches them. Then that is when a patient will come and tell you, when I go for long call, after passing the first bolus of stool, There's like blood dripping,
Yeah.
or there's fresh blood dripping or tickling into, what is the correct term? There's pouring and there's dripping. So there are people who experience pouring, like a heavy flow. Then there are people who experience dripping. And you may also see them in the tissue bed. They may just complain of that. There are people who now would come with itch. Why? Because when they are engorged like that, the anal canal is designed to produce a lot of mucus to make stool slide and pass through it. So they trap a lot of mucus. Now that mucus traps some particles of stool. Now when it stays around your anal canal, the bacteria ferments them and it produces gas. Now that gas makes you itch and you get irritation. So some people just come with bleeding and itchiness or irritation. Because of that mucus and those particles, you may soil your underwears at the end of the day. So some people will come with soiling. Then there are people who will tell you when I pass, something comes out, but it goes in. Now that one you have to be careful because there's something called rectal prolapse. So you have to know the difference between hemorrhoid that comes out and goes back vis-a-vis a rectal prolapse. Now some people may come in acute pain. Why? Because one of the hemorrhoid tissue may get very engorged with blood. Then the blood clots inside. Now we get something called thrombosed hemorrhoid. Then some people just tell you when they sit, they get discomfort. So probably those are the common complaints that people come with. And who are the group that are likely to get hemorrhoid? Teenagers. Wanapenda kula chipo, they like eating chips and these other things without fiber. Chips and soda. So people who don't eat a lot of fiber in their diet, people eat refined meals. People like sausages, samosas, and all those things.
Yeah, no fiber.
But in fact, we normally say, adui ya hemorrhoid, the enemy of hemorrhoids are vegetables, a lot of fiber, and water. Because once you do that, then your stool is able to be soft. You don't need to strain. Then you will not have hemorrhoid. But then again, there are that group that I've told you. The people who do heavy lifting, people with chronic cough, people with constipation, people who stand long hours, people with things like asthma, chronic airway diseases, because they put a lot of pressure on their pelvic veins. When they put a lot of pressure, the pressure goes down in the hemorrhoid plex. So such kind of people are prone to getting hemorrhoid. The other group is the people who read newspapers in the toilet. It's very bad. The people who chat a whole hour seated on the toilet bowl.
All right.
It's a bad habit. So probably those are some of the risk factors that makes people get hemorrhoids. And I always say hemorrhoid is a preventable disease. You just need to do the right thing with your diet. And you'll be well.
But men, we see them.
Now, when you get them,
yeah,
when you come to our clinic, we'll examine you, we'll take history. We give medicine. There are medicines that we give to soothe those itching, those bleeding, and we give medicine to shrink the hemorrhoid cushion. If they don't shrink, then we are able to operate on them, and there are many procedures. Nowadays, there are modern procedures like laser, ultrasound ablation. We even do colonoscopies and tie them with rubber band ligation. And even surgeries, there are different techniques. There's the normal conventional open surgery. There are the machines that we use that are stable. But we grade them. Most of the people who have grade 1 and 2 don't necessarily need surgery. Most of the people with grade 3 and 4, then a good number of them end up getting surgery. So now, as to what you have, if you have hemorrhoid, see your doctor. Let them check on you because hemorrhoids, there are people who have been treated for years. Somebody has been treated for like 4 or 5 years for hemorrhoids. When they come, you come and find that they have cancer of the anal canal.
Wow.
Then you find that this patient lost 4 or 5 years being treated for hemorrhoids. When had he seen you 5 years ago, you'd have dealt with that anal cancer at that particular time. So every bleeding is not equivalent to hemorrhoid. But painless bleeding is treated as hemorrhoid initially, but you need to see a specialist because we may need to do special tests. We may need to look at your whole colon. Cancers can bleed. Things like polyps can bleed. Inflammatory bowel diseases can bleed. malformations of blood vessels can bleed. So anybody who has rectal bleeding is a patient you don't take lightly, because that is the problem. Many of them are being treated for two conditions, amoeba and hemorrhoids. And by the time they come to you, you find they have advanced cancers that have progressed. That is not to scare people, but it's just meant to say that not every bleeding that is painless or painful is equivalent to hemorrhoids. Thank you.
So, Doc, before we close up, I've been seeing you to do OGD to several clients. At what time is it necessary? Why are you doing it? And any light that you want to put around the area, and when they need your services, where they can find you.
So now there are other things that we need to know. We are in an area, in an era that the world has transformed. There are a lot of men who are having sex with other men. Those are other predisposing factors. There are people who are probably psychiatric. They pack themselves with things. Those are probably another group. And other surgeries can also predispose you to hemorrhoids. Yeah. So it's always good to have all round. Now for hemorrhoids, there's no a screening. You only come to us when you have symptoms. But the only message is, let your doctor not tell you that your bleeding is hemorrhoid until they've ruled out all other causes of bleeding and only left hemorrhoid as the only documented, not postulated, but documented. How? Most of the time, patients with bleeding, the bare minimum would be to do a colonoscopy. Yeah. You scan the whole colon and confirm it is only hemorrhoid. Because you can have a patient who has a tumor up there that is blocking blood flow, predisposing to hemorrhoid down here. So while you may be treating hemorrhoids, the tumor is growing up. So the message that I have for the men, and this is one even for ladies, because hemorrhoids is across. Any bleeding must be given the seriousness that it deserves. And until a proper workup and tests are done, and it has been proven to be hemorrhoids, that is when, as a doctor and as the patient, you can have your peace as you get treatment. Otherwise, let not your doctor tell you that every bleeding you come with varicose is hemorrhoid. That is where we have lost the battle. When you could have sorted out problems early, then you end up now getting them when they are beyond your control. But otherwise, there's no screening for. The only screening we have is bleeding. So that is not be called together. Yeah. Because now that relates to colorectal cancer and other risk factors for colorectal cancer.
All right. So there's that. The question was asking about the OGD screening, which is you're doing it more commonly right now, and it's an area that you're specialized at. At what time do I come and now need an OGD examination as a client?
Now, this one is two ways. So let's start with the OGD. Everybody who is above 50 years ideally should have an OGD at least done. It's not in the guidelines recommended, but ideally. Yeah. Anybody who's above 50 years with any complaints of ulcers or being treated for ulcers must have OGD done. Yeah. Anybody who has been treated for ulcers for quite some time, at least 3, 4, 5 years without response. Actually, even 3, 4, 5 years is long. Anybody who has been treated for ulcers for at least 1 year or so without much response must get an OGD done. So, yeah. Now, people who have family history of stomach cancers, at least by 50 years, 5 to 10 years earlier than when your first degree relative was diagnosed, needs to have an OGD done. Now, the tricky one is colonoscopy, because now that one will take 1 hour here discussing the guidelines. Because there are those ones with proven syndrome. Yeah. There are those ones with family history. There are those ones with disease. And there are those ones who are risk factors. Then there are those ones who are the normal people. So now that one is tricky. It depends. But basically, everyone should have a colonoscopy by 50 years. Anybody who has had a relative who has a colon cancer must have a colonoscopy 10 years earlier than, if, for example, your relative was diagnosed at 40, by 30 years, you must have a colonoscopy.
Wow.
Anybody who has a genetic syndrome For there are certain genetic syndromes that we start doing colonoscopies at 12. There are those ones we start doing at 20. So that one is a very tricky discussion. It depends on who, but the bare minimum is anybody who has bleeding per rectum that cannot be explained by anything else should have a colonoscopy. For your own safety, if you have any bleeding per rectum, please go for colonoscopy.
Right.
It costs you nothing by having the screening and finding that your colon is normal, then assuming it is hemorrhoids and finding you had cancer or you had inflammatory bowel disease that can dispose you to cancer 10, 15 years down the line. Right? Yeah. So probably that is summary. Because then if you want to understand them proper, then you have to pick each one and sit on it.
Yeah. So lastly, if someone wants to look for you, they're having all these things, where do they find you?
Yes. So in Nairobi, I am at Luton Hospital. I also go to Megalite. I also go to Metropolitan Hospital. In Kirinyaga, you can find me at Kimbimbi Sub-County Hospital, Kerugoya Medical Center, Moya Medical Center, Kajia Nursing Home. Basically, all those hospitals in Kirinyaga,
Okay.
private and Kimbimbi Sub-County Hospital.
All right.
That's where I work, so you can find me.
Thank you so much. God bless you. You're doing a good job.
Thank you. You're also doing a good job because actually the point is when you look at healthcare in the West, healthcare is driven by data. Like if we were to run a good healthcare in Kenya, right now we should have a system that's synchronized. And I'm happy they're trying to bring something called digital health agency, whereby at the end of the year, all patients seen for hemorrhoid are documented.
Yeah.
Then we can know this in 2025, how many patients did we have for hemorrhoid?
Yeah.
How many underwent colonoscopy? Then how many were diagnosed to have much more problems beyond the hemorrhoid? Then from there, the policy makers can now make a plan on how to deal with them. They can budget. In the West, they have a very strong epidemiological systems where they know, like for example, we know here malaria is endemic. So there's a very tight malaria program.
Yeah.
So like somewhere in Japan, they have a very tight screening program for gastric cancer. It is envisioned like in our, like if showers in Japan, it's in their program. So there's an age that you reach, you go for screening. There's a type of a family that you come from. At a certain age, you must have undergone that screening and they put them in record. So where we've reached now, digitalization of health is would be the way to go, because then from there, if I sit here in my house, I can log into the digital health agency and know what is the incident rate of colorectal cancer in Kenya based on data. Like I just log in live and see that this year we had 4 million patients across the hospitals. Out of them, 2,000 had colorectal cancer. So the second one is advocacy. Advocacy is important because right now we are moving from treating to screening and preventing. Screening is actually part of prevention. So whatever you're doing is a very good job. And if we would move health to that level, I can see one of the pillars was in showers community, where there are community health workers who are supposed to visit you, do health education, then from there screening takes place. It's a very noble idea, but the other politics around SHA, you have to see them. That's but it's a noble idea.
Thank you so much. Thank you so much for your time.
Thank you.
I'm sure this message is going to reach so many people, and I'm going to give you the feedback.
Thank you.
Yes.
And if people have questions, we can also create a forum where people can do one-on-one and we take their questions and answer.
That will happen. That I'll make sure it happens.
Thank you.
Thank you so much. Bye.
Asante sana and have a blessed day.
You too. Enjoy. I hope you had some pointers. I hope you wrote down points that not only you can share, but you can tell someone else to watch the show, to watch and listen. You know, there is that guy that you know, maybe a boyfriend, a father, that this information will be very of more importance to them. Kindly share it, talk it out, write up some notes, go redo, listen to it cautiously as you write up some notes on things that would be important for you in the future. So these can only be happening at your nurse companion, where we discuss these things, when we discuss about health advocacy, the importance of it, and bring some light to your house. And I'm glad to do it. I will go to whatever length in Africa and beyond to make sure that you have all the health information that is needed for you and your family. Only at your nurse companion show, where we go on every social media handle. We are at X, YouTube, Facebook, in your nurse companion social handle, and you Oasis of Love TV. We will be going there, and you can get all the information, ask questions, respond, give us your comment. We are ready to walk the journey of health with you. Bye.